Hi guys, good morning. So today we are going to discuss about the projection geometry and the intraoral radiography. So before discussing these, let's discuss what is radiograph. So the radiograph, it is a two-dimensional representation of a three-dimensional object. Right? Coming on to the principles. So in these principles are very important for your MCQ point of view. So the focal spot, it should be as small as possible. The focal spot and the tooth distance, it should be large. The tooth and the film distance, it should be small. The tooth and the film, it should be parallel. And the X-ray beam, it should be perpendicular to the tooth or the film. The tooth, it should be positioned in the center of the film. So next is the image sharpness and the resolution. Coming on to the image sharpness. So the image sharpness, it is the measure how well a boundary between the two areas of the differing radio density is revealed, while the image spatial resolution is the measure how well a radiograph is able to reveal the small objects that are close together. So the image sharpness and the resolution, these two are the distinct feature as they are interdependent. These two are interdependent. Now let's discuss about the image sharpness and the resolution. So as you all know, this is the anode and there is a filament and a focusing cup and a cathode. So the electrons, it moves from the cathode to the anode at a target point, and from there it get convert the electron energy get convert into the X-rays, as we have already discussed in our previous lectures. So when the X-rays, these are produced at, this is the target or the focal spot. So when the X-rays produced at the target in the X-ray tube, so it originates from the different point and they travel in a straight line from the target point or from the focal spot. They travel in a straight line. Fine. Their projections of the features of an object, they do not occur. See, this is the image receptor. So when the X-rays, these are produced on the target, when they get converted, so when they hit to the image receptor, they are, or you can say they do not occur at exactly at the same location. See, it occurs at a different location, it occurs at a different location. Therefore, it occurs at a different location, it occurs at the different location on the image receptor. So in this, the image of the edge of an object, it is slightly blurred. So there is, this point is the unsharpness. So in this, the image of the edge of an object, it is slightly blurred. See, when there is a large focal spot, the X-rays, this is the target area, this is the large focal spot. So in this, the X-rays, these are originate from the different points. See, it originates from the different point, it originates from the different point. Same with this originate and this originate from the different point, but they move in a straight line. They move in a straight line. Fine. And their projection, now they project onto the image receptor. This is the image receptor. See their projection. This occur at this line, it occurs at a different location, it occurs at a different location. Same with this occur at a different location and this occur at a different location. So they are not occur exactly at a same like if they occur in a same position. This is what we call as they occur in a same location, but in this they occur in a different location. So this is the result, that this is the point of the unsharpness which increases. When the point of unsharpness it increases, in this the edge of the object, it gets blurred. Right? When the area of the focal spot is small, or you can say when there is a small focal spot, they also originate from the different projections, right? But they also travel in a straight line, but in this they almost located on a same location, or you can say they occur almost in a same location. See, they occur almost in a same location. So in this, can you see this? This is, in this, the unsharpness, it decreases. When the unsharpness is decreases, in this there is no blurring of the edge of the object and the image is sharp. But when the area of the unsharpness it increases, there is blurred edge of an object, and in this the image is not sharp. So this is the basic difference. When there is a large focal spot, there is a small focal spot, right? So the important is that the resulting blurred zone, of the unsharpness, this is the blurred zone of the unsharpness on an image. Important point, it causes the loss of image clarity by reducing the sharpness and reducing the resolution. Fine, I'm repeating it again. When the area of the unsharpness increases, it leads to the blurred image and there is no sharpness of the image. When the zone is blurred, the resulting blurred zone of the unsharpness on an image, it causes the loss of the image clarity by decrease the sharpness and resolution. So in this, so there are three methods which is used to maximize the image sharpness, because when we using the large focal area, it decreases the sharpness. So there are the three methods which are used to maximize the sharpness. So first one is the use of a small and an effective focal spot as practical. See, in this, when we use the small focal spot, it leads to decrease in the unsharpness. Can you see this? There is a decrease in the unsharpness. When we are using a longer focal spot or a large focal spot, there is increase in the area of the unsharpness. But when we are using the small focal spot, it leads to decrease in the unsharpness and increase in the image sharpness. See, decrease in the unsharpness while increase in the image sharpness and resolution. So I'm repeating it again. First method to maximize the image sharpness is the use of the small focal spot. It leads to when you are using a small focal spot, it leads to decrease in the unsharpness, increase in the image sharpness and in the resolution. Next is the angle. Important point, the angle of the face of the target to the central X-ray beam, it is usually 10 to 20 degree. Important. Second method is increase the distance between the focal spot. So in this is the focal spot and the object, and this is the object. So by increasing the distance between the focal spot and the object by using a very important commonly asked question, by using the long open-ended cylinder, it reduces the image blurring by reducing the divergence. divergence of the X-ray beam. Important. See, when you are using a long open-ended cylinder, it leads to the increase in the distance between the focal spot and an object. So when there is an increase in the distance between the focal spot and an object, it leads to decrease in the divergence. See, and when there is decrease distance between the focal spot and the object, it leads to the increase in the divergence. Very important point. So next important point, that the longer is the focal spot to the object distance, it minimizes the blurring by using the photons whose paths are almost parallel. Fine. So second one is to increase the distance between the anode, to increase the distance between the focal spot and the object, it leads to decrease in the divergence, which leads to decreases in the image blurring. Fine. And it increases the sharpness. And third one is minimize the distance between the object and the image receptor. This is the image receptor. So by reducing the distance between the object and the image receptor, it leads to increase in the sharpness. By elongating the distance between the object and the image receptor, in this there is decrease in the sharpness. Fine. So when you are minimize the distance between the object and the image receptor, it leads to the decrease in the unsharpness, increase in the sharpness, and it enhanced the image clarity. It also leads to minimizing the divergence. Fine. So these are the three methods to maximize the image sharpness. So here I am writing it again. Number one, if you decrease the focal spot, it leads to the increase sharpness. These are commonly asked MCQs. Second method to maximize the image sharpness is to increase the distance between the focal spot and the object. It leads to increase in the sharpness. Third one is decrease the distance between the object and the image receptor. It leads to increase in the sharpness. So this is all about the image sharpness and the resolution. And yes, these are the factors which increase the sharpness. One important factor is the movement of the tube, the movement of the patient, and the movement of the film. It decreases the sharpness. Don't get confused. These are the factors which decreases the sharpness. These are the methods which increase the sharpness. Important. So after this, coming on to the image size distortion, second one. So in this, increasing the focal spots to the image receptor distance and decreasing the object to image receptor distance, it minimizes the image magnification. Right? So the use of the long open-ended cylinder as an aiming device on an X-ray machine, it reduces the magnification of the images on a periapical view. So I am writing here the factors that influence the magnification. Important point for your MCQs. Number one is the target and the film distance. Next is the object to film distance, FD. And third one is the use of intensifying screens. So these are the factors which influence the magnification, the target to film distance, object to film distance, and the use of the intensifying screens. So as we have already discussed this, that increasing the focal spot to the image receptor distance and decreasing the object to the image receptor, decreasing this and increasing the focal spot to image receptor, it minimizes the image magnification. So next is the image shape distortion. So this situation, it arises when not all the part of the objects, these are at the same focal spot to the object distance. Such a phenomenon, it is seen by the differences in the appearance of the image on a radiograph compared to the true shape. So in this, there are the two methods which are used to minimize the shape distortion. So first one is the position of the image receptor parallel to the long axis of the object. See, when a central ray X-ray beam, it is perpendicular to the image receptor. So this is the X-ray beam, it is perpendicular, this is the image receptor, this one. So the X-ray beam, it is perpendicular to the image receptor, but this is the long axis of the object. See, this is the long axis of an object, but the object, this is the object, it is not parallel to the image receptor. This is the long axis and this is the image receptor. The object, this is the object, this is not parallel to the image receptor. So this type of this type of the shape distortion, this is called as the foreshortening. Fine. So in this, the resultant image which is formed, it is distorted. Why it is distorted? Because of the unequal distance. Because of the this and this, because of the unequal distance. Unequal distance of the various part of the object from the film, from this to this. Right? And why we called it foreshortening? Because it causes, important, it causes the radiographic image to be shorter than the object. That is why we called it the foreshortening. Fine. So after this is second in the position of the film parallel to the long axis is the elongation. Elongation means long. So in this, the X-ray beam, it is oriented right angle. Now the X-ray beam, it is perpendicular to the object, fine, but it is not to the image receptor. So in the first one, the X-ray, it was perpendicular to the image receptor, but in the second condition, the X-ray beam, it is perpendicular to the object, but it is not to the image receptor. This is the long axis of the image receptor, this is the X-ray. So this is not perpendicular. So this results in the elongation. So in this, the object appearing longer on the film than that of its actual length. That is why it results in the elongation. Now coming on to the second method. So second method is the orient the central ray. This is the central ray which is perpendicular to the object. This is the object and the image receptor. This is the image receptor. So in this, the image shape distortion occur if the object and the image receptor, these are parallel. I'm repeating it again, very important. See, the image shape distortion occurs only if the object, this is the object, and the image receptor, these are parallel. But the central ray which is directed these are not at the right angle to each. So this is the long axis of the object, this is the long axis of the image receptor. So these both are parallel to each other, but the central ray or the central X-ray, it is not directed at the right angle to each of the object or to the image receptor. So this distortion, it is most evident on the maxillary molar projections. Important. Fine. It is most commonly occur in the maxillary molar projection. Important point that the practitioner, it can prevent this type of distortion by aligning the object and the film parallel to each other with, very important, and the central ray perpendicular to both this object as well as to the image receptor. So when the X-ray, central X-ray rays, it gets perpendicular to both the object as well as to the image receptor, at that point of time there will be no distortion. But if it is not perpendicular, it causes the image shape distortion. Right? So after this, coming on to the techniques. So we basically use the two techniques to take the periapical radiograph, that are the paralleling or the right angle or the long cone technique. Important, the names also. The bisecting angle or the short cone technique and the slope technique, that is the same lingual and opposite buccal. Starting with the first, that is the bisecting angle technique. Very important, please write it down. Number one, it is based on Szyczynski rule of isometry. Commonly asked question. So what is the Szyczynski rule of, or you can say the rule of isometry? So in this, the two triangles, these are equal if they share on completes or one complete side and they have the two equal angles. I am repeating it again, that the bisecting angle technique, it is based on the Szyczynski rule of the isometry, in which the two triangles, these are equal if they share the one complete side and they have the two equal angle. It is also known as the short cone technique, SCT. Right? So in this method, the film, it is placed as close to the teeth as possible without deforming. So when the film is in position, it is not parallel to the long axis of the teeth. See, this is the long axis of the teeth and this is the film. So in this method, when the film, it is placed as close as to the teeth, and in this, the film, when it is in position, it is not parallel to that of the long axis of the tooth. And this arrangement, it causes distortion. Please write it down. Very important and commonly asked question, that the distortion of the image, it is more commonly seen in the bisecting angle technique than that of the paralleling. If a question comes, distortion of the image is more common, or it is more commonly seen in which of the following techniques, so your answer should be bisecting angle technique. Fine. Now there are two more points. See, in this, when the central X-rays, it is not perpendicular to the bisector plane. So in this, the length of the image of the projected tooth, it get changed, and if the central X-rays, these are directed at an angle which is more positive than the perpendicular, and it is perpendicular to the bisector, the image of the tooth which is formed, it is foreshortened if it is towards more positive. Likewise, if it is towards, or you can say if it is inclined with the more negative, see more positive, it means foreshortened, and if it is inclined with the more negative angulation to the bisector, the image is elongated. These 2 points very important for your MCQ. So these are some of the angulation guidelines for the bisecting angle projection. It is in the maxilla and the mandible. So in the incisor, it is plus 40 degree in the maxilla, while it is minus 15 degree in the mandible. Canines, it is plus 45 degree in the maxilla, minus 20 degree in the mandible. In the premolar areas, it is plus 30 degree in the maxilla, minus 10 degree in the mandible. While in the molars, it is plus 20 degree in the maxilla and minus 5 degree in the mandible. So the advantages of this technique. This can be used without the film holder. Important. It is comfortable for the patient. It is less time in this. The less time is required to shoot an X-ray. Coming on to the disadvantages. So in this, you can see a maximum image distortion and the magnification. It is technique sensitive. It usually retakes, and it is not reproducible. In this important point, that superimposition of the zygomatic buttress over the upper molars, very important, commonly asked MCQ. So next is the paralleling techniques, important. So in this, the film, it should be, this is the film, it should be placed parallel to the long axis, but in that bisecting, this is the long axis of the tooth, and the film, it should be placed as close as to the tooth. So this angulation, it causes the distortion in the your bisecting. But in this paralleling technique, in this, the film, it should be placed parallel to the long axis of the tooth, and the central X-ray of the beam, it is directed perpendicular to the film and long axis of the tooth. So this is the central axis of the tooth, and this is the film. These are parallel to each other, and the central X-ray of the beam, it is perpendicular to the tooth as well as it is perpendicular to the film. So in this, a film holder, it must be used to keep the film parallel to the tooth. But in the bisecting technique, we will not use the film holder to shoot an X-ray. But in the paralleling technique, in this, a film holder, it must be used to keep the film parallel to the long axis of the tooth. Fine. So the advantages are the accuracy. So in this, the image produced has a dimensional accuracy and free of distortion. Simplicity, it is simple and easy to learn and use, and it is easy to standardize, and it can be accurately repeated. So one important point in this paralleling technique is the use of the, in this you can also use the long open-ended cylinder. What is the use of using the long open-ended cylinder? To increase the focal spot to the object distance, and this leads to, or this avoids the distortion. Very important, commonly asked question, that what is the use of using the long open-ended cylinder in a paralleling angle technique to avoid the distortion. Very important, commonly asked MCQ, and also it causes the less magnification with increased definition. These 3 points are very important. By using the long open-ended, it increase the focal spot to the object distance, which leads to avoid the distortion, causes less magnification and increase the definition. Coming on to the disadvantages. Disadvantages is the film placement. So it requires the film holder to place the film parallel to the long axis of the tooth, which is difficult to place in the children and in the small mouth patients. The anatomy sometimes make technique impossible. Example, the shallow palate and the third molar region, and it causes the discomfort to the patient. The positioning of the film packet, it can be uncomfortable to the patient. So coming on to the distinguished features or the distinguishing features between the bisecting and the paralleling technique. So there are distortion of the image. It is most commonly seen in the bisecting, while there is very less amount of distortion we can see in the paralleling technique. The superimposition of the zygomatic bone is seen in the bisecting, while there is no superimposition of the zygomatic bone in the paralleling technique. There is a cone cut which is present and we can see in the bisecting technique, while the cone cut it is not present in the paralleling technique. The alveolar bone fills interproximal space. It is seen in the bisecting, and there is a true relation which is seen in the paralleling technique. It is easier and decrease the space bisecting, and long teeth it is seen by the vertical angulation in the bisecting technique. So next is the slope technique. So the slope technique, it is the same lingual and opposite buccal. So indications are very important. It is basically used in the overlapping canals, examples in the mesial root of the mandibular molar, in the retained roots and unerupted teeth, and in the foreign bodies. So it is also called as cone shift technique, the mesial shift, the Clark's shift. Why it is known as the Clark's shift? Because it is described by the Clark in the year 1910, and it is also called as the buccal object rule, and it reveals the third dimension. Now coming on to the diagrammatic representation. So in this, see, when the object is placed in the lingual direction, it moves in the same direction as that of the cone. It means when we place the object in the lingual direction, it moves into the same direction. Same way, when we place the object in the buccal direction, it moves in the opposite direction. So same SL, same lingual, opposite buccal. Fine. I am repeating it again. When you place the object in the lingual direction, it moved into the same direction as that of the cone. When you place the object in the buccal direction, it moved into the opposite direction. That is why it is known as slope technique. Same lingual, opposite buccal. So slope, it is a method which is used to determine the relative position of the two objects in the oral cavity by using the projectional dental radiograph. Fine. So after this, after the periapical radiograph, coming on to the bite-wing. So it is also called as interproximal radiographs. This includes the crown of the maxillary as well as the mandibular and the alveolar crest of the on the same film. So this is the bite-wing. Indications commonly asked, it is basically used for the detection of the interproximal caries, monitoring the progression of the dental caries, the detection of the secondary caries, important, below the restoration, evaluating the periodontal conditions, useful for evaluating the alveolar bone crest and changes in the bone height. It can be assessed by comparison with the adjacent teeth. To detect the interproximal calculus for the better visualization, the exposure should be reduced as the calculus it has a relatively low density. So in this, the principle is the film, it is placed in the mouth. This is the film, it is placed in the mouth parallel to the crowns of both the upper and the lower teeth. So in this, the film, it is stabilized with the when the patient bites on the bite wing. This is the bite wing tab. So this is the film which is parallel to the crowns of the both upper and the lower teeth. There is a slight, not more, there is a slight bending of the film. So the film, it is stabilized when the patient bites on, this is the bite wing tab of the bite wing holder. So in this, the X-ray of the the central X-ray of the X-ray beam, it is directed through the contacts of the teeth. This is the contact of the teeth. These are the contact. So in this, the central X-ray of the X-ray beam, it is directed through the contacts. It is using the +10 vertical angulation. Very important, commonly asked question. Right? So this is the central ray of the X-ray beam, which is directed through the contacts. This is the slight bending of the film, which is placed parallel to the crowns of the maxillary as well as to the mandibular teeth. So the bite-wing films, we are using the size 0, we have already discussed, which is 22 to 35, which is used in the posterior region of the child. Size 1, 24 into 40 mm, which is used in the anterior region of the child. The size 2, which is the ideal size, and it is used, which is 31 into 41 mm. It is used in the posterior portion or the posterior region of the adult, while size 3, it is 27 into 54 mm. It is used in the anterior region of the adult. Fourth one and the last one is the occlusal radiography. It is also known as sandwich radiography. So in this, the intraoral technique in which the large occlusal areas of the maxilla and the mandible are recorded. So the size we use is size 4, that is the 57 mm into 76 mm. So the indication, it is used to detect the trismus, precise location of the roots, supernumerary, unerupted and the impacted teeth. Commonly asked MCQ. Calculi in the salivary gland duct, also very important and commonly asked. Maxillary sinus, trauma, size and extent of the cyst and the tumors, the position of the unerupted canine. Indications of the bite-wing and of the occlusal radiograph, these are very important. So the principle is, the film, it should be positioned with a wide side facing the arch which is being exposed. So the film, it is placed between the occlusal surfaces of the maxillary, and this is the film. So the film, it is placed between the maxillary and the mandibular occlusal surfaces. So the film, it is stabilizes when the patient bites on the surface of the film. When the patient bites, the film gets stabilized. So for the maxillary occlusal films, the patient head, it must be positioned so that the upper arch, it is parallel to the floor, and the mid-sagittal plane, it is perpendicular to the floor. Perpendicular to the floor, and the upper arch, it is parallel to the floor. While for the mandibular occlusal films, the patient heads must be in a reclined, and it is positioned so that the occlusal plane, it is perpendicular to the floor. So the occlusal plane, it is perpendicular to the floor. So the angulation for the maxillary and the mandibular, in the cross sectional, it is +65 for the maxillary and 9 degree for the mandibular. Topographic +45 for the maxillary, -10 for the mandibular. Lateral +60 for the maxillary and -55 for the mandibular. Now coming on to the film surveys. So in this, we have starting with the age of 3 to 12 years. So in this, first we have the 4 films, which includes the 2 anterior, guys, this is very important, commonly asked, 2 anterior occlusal plus 2 bite-wings. Second is the 8 film survey. It includes the 4 posteriors plus the 2 anterior occlusal plus the 2 bite-wings. Third one, which includes the 12 film. It includes the 4 posterior IOPA plus 4 canine IOPA plus 2 incisor IOPA plus 2 bite-wings. Last, is the 16 film survey. It includes the 12 film survey, this one, plus the 4 permanent molar radiographs. Fine, so these are the film surveys, which includes the 4 films, the 8 films, 12 films and the 16 films. Now coming on to the ages, their concentration and their radiographs. See, at the age of 3 to 5 years, number 1. So the concentration is when there is nothing abnormal, when there is open contact, open contact or the closed contact. In these case, there is no requirement for any kind of the radiograph. But if there is extensive caries, in this you prescribe the 4 film survey, which means 2 anterior occlusal radiograph and 2 bite wings. Right? And if there are deep caries, so in this case you prescribe the 4 film survey plus the IUPA of a selected tooth. Second condition or the second age is between 6 to 7 years. If there is nothing abnormal, then you can go for 8 film survey, which includes the 4 posterior, 2 anterior occlusion and 2 bite wings. And when there is extensive caries or the deep caries, for that you prescribe the 8 film surveys plus the IUPA of the selected tooth. At the age of 8 to 9 years, if the patient or the child have the extensive or the deep caries, in that you prescribe the 12 film survey, which includes your which includes your 4 posterior IUPA, 4 canine IUPA, 2 incisor IUPAs and 2 bite wings. Lastly, at the age of 10 to 12 years, if the patients have the same condition like the extensive caries and the deep caries, for that you prescribe the 12 film survey or the 16 film survey. Right? This is very important. So this is all about the projection geometry and the intraoral radiography. Very important topic. Please go through it once and try to make the notes. Thank you.